I want to introduce our panel. Some of you may know them. So Dr. Bruce Brundage, he's kind of the one of the gurus of pulmonary hypertension, and he's Professor Emeritus at Debunking School of Medicine at UCLA. And we have Mary Whitenhall, and she's an advanced nurse practitioner with pulmonary critical care up in Rhode Island Hospital at the Pulmonary Hypertension Center there. And then my name is Brandy McKlevy, and I do pulmonary hypertension and pulmonary critical care and sleep medicine down at UT Houston in Houston. So we will just talk about a few things regarding some of the myths surrounding pulmonary arterial hypertension. There may be a little bit of overlap with Dr. Sager's group from yesterday, so we apologize if you've already heard it. Maybe you'll hear it a little differently today. And then we're just going to talk for a few minutes, and then again, it's interactive for you guys to ask whatever questions you want, and we want to encourage those questions, and we'll answer those as best we can. So my topics are really going to be talking about oxygen usage and then a little bit about exercise. So if we start from the beginning, oxygen is the most important fuel that the body needs, okay? So oxygen and glucose, you need those two things to survive at all times. Interesting fact you may or may not know is when you don't have enough oxygen, your tissues go into what's called anaerobic metabolism. I know that sounds a little bit fancy, but that just means lack of not enough oxygen. And when you don't have enough oxygen to your tissues, you start to build up what's called lactic acid. Lactic acid is a waste product that you then have to get rid of, and it's metabolized through your kidneys, through your liver, and then you actually eventually have to breathe it off. So just by lack of having oxygen to the tissues, if lactic acid builds up, you have to breathe faster. So it's kind of an interesting circle. And everyone builds up lactic acid. Those marathon runners and swimmers and all those guys, they build up lactic acid too, but they get rid of it pretty easily. So we want to try to keep you out of anaerobic metabolism at any time. So if we're offering you oxygen or suggest that you need oxygen, that's kind of the logic behind it. And when do we recommend that oxygen? It's at any point that your oxygen level goes below 90. So 90 is when that curve kind of falls off, and that your body has to work harder if you're below 90. And that can be either at rest, while sleeping, or with exercise. So your doctor will probably recommend one, if not all of those situations as to when you would need the oxygen. And in fact, when that oxygen level is low, what happens in the lungs is the blood vessels get tighter, okay? And you guys know from having pulmonary hypertension, when those blood vessels get tighter, the right side of the heart has to work even harder. So oxygen is one of the best vasodilators we have, and so we want to keep those blood vessels relaxed as much as we can and keep that blood pumping through the heart and lungs. In fact, that's what some of the medicines that you guys are taking also tries to do, is relax those blood vessels. But oxygen is an important component of that. So I use a little bit of an example that your blood is like a train on the tracks. And so, the right side of the heart pumps those train cars into the lung, and then the lung, those train cars take the oxygen. So when you have pulmonary hypertension, that whole system slows down, the train moves much slower, and thus the only way to get more oxygen molecules into the cars, the boxcars, is to supply the supplemental oxygen, okay? Otherwise, those boxcars can only take up a certain amount, and we have to give you extra oxygen by your nose to load up the boxcars to get it downstream to the tissues. What else was I going to say? Just that, the low oxygen level, in fact, people can develop pulmonary hypertension solely from low oxygen level and the blood vessels getting constricted. The other thing I was going to mention was just that you can't predict, without measuring your level, oxygen level, exactly how low it is or how high it is. I know some people feel like they can tell when it's low, and you're probably right that you're predicting, if you're feeling worse, that your level be low. But some people can have a low level. Some people walk into my office and their level is 78 or 79 and they don't feel it, okay? But there's something happening inside their lungs that can be detrimental even though they don't feel it yet. So our goal, of course, of giving you supplemental oxygen is to make you feel better, make your tissues get more oxygen, and make sure that the right side of the heart is pumping as best that it can. So the other two comments about oxygen is that you absolutely should not smoke. First of all, if you're wearing oxygen, you shouldn't smoke anyway, which is a bad combination. We can probably tell you the patients that we've seen. I've taken care of several of them who I have one in the hospital right now who's burned their face by using oxygen and smoking. But moreover, when you smoke, the carbon monoxide in the smoking bumps some of the oxygen off those train cars. So we need all we can, so we certainly don't want to risk by smoking also. And then the final point really is that you're not going to become addicted to the oxygen. There's a reason that you need it. It's because your body needs it. So it's a little bit counterintuitive to say, like, well, you're not going to make your lungs worse by using it. You're just going to make yourself feel better by using it. Okay? But it's not addictive. Okay? There are some patients who, once they get started on other medicines for pulmonary hypertension, they may be able to come off their oxygen, and so that's always an important question to ask your doctor, but that's not everybody. Okay, a good number of patients will be on medicines and still need oxygen. All right, so I'm going to turn to exercise briefly and mention a few things about exercise. Even though you have pulmonary hypertension, you should still exercise, okay? And it may be a smaller amount than anybody else, but a certain amount of exercise is important. It's something you should discuss with your doctor if you're planning to start an exercise program, or at least discuss with them what level of exercise you're going to participate in. So we want to encourage you to do that, but we are not going to expect a marathon out of you guys, and that's fair. When you're dealing and living with pulmonary hypertension, the left side of the heart can also get a little bit weak. And so exercise makes sure the left side of the heart is working still, and puts a little bit of strain on that left side that you can keep your body toned and keep your muscles happy. In fact, one of the things a lot of people don't know is that toned muscle uses oxygen more efficiently, to tie back to the oxygen part, more efficiently than flabby muscle. Okay, so we do want you to have a little bit of exercise on board. It is important to work with your doctor to decide what that is going to be. Most of the time we're going to recommend that you either do upper body or you do lower body at a time, not both together, because that is going to put an increased work on your heart. What else would I want to tell you? There is no one-size-fits-all workout plan, so we have to take each patient individually and decide what level of exercise. If you're newly diagnosed or changing meds or not sort of at that sort of stable, and I use the term stable loosely because we know our pulmonary hypertension patients are not always stable, but if we're rapidly changing things, that may not be the best time to start an exercise program. If you are checking your oxygen level while you're doing your exercise, again, the goal would be a SAT greater than 90% to make sure you're in the safe zone. Also, when you initiate that exercise program, it would be good to be with the trainer or with the loved one or with a caregiver, just so that you kind of feel safer and you're protected in case something happens while you're exercising. What else did I want to say? There's a variety of programs and workout that you can do. You can do swimming, you can do yoga. I saw the sign out for yoga this weekend. It doesn't have to be, labor intensive. A small amount of exercise can do really good. And that being said, remember your weight is a balance of the number of calories you take in and the amount of calories that you get rid of with your exercise. So if you're not able to exercise at all, and Mary's going to talk a little bit about that, diet becomes a very important part of your lifestyle. The only other thing I wanted to mention about exercise is that interesting study that came out in 2006, Derliz Morales in Germany, and he took 30 patients who all had pulmonary hypertension and put them through a rigorous exercise program. Started as inpatient, finished as outpatient. It was 15 weeks. They did cycle ergometry, so the upper arm exercise bike, 60 minutes of walking, and 30 minutes of low weightlifting. And they did that for 15 weeks. And the outcome of that study was actually on average, a 96-meter improvement in walk distance, which is dramatic, especially in the world we talk about where we're looking at small increments in 6-minute walk distance, even with the medications we use. So it's just to sort of highlight that we do want you to do a little bit of exercise. We don't want you to do it to the point that you pass out or feel dizzy or any of that. That's too much, okay? But it can be very helpful. Does anybody want to ask a quick question about that in the meantime? Yes, ma'am.
Sometimes my mom says when she doesn't get enough oxygen, her eyes start getting fuzzy.
Yeah, so
first.
Yeah, that may be kind of a preamble to syncope, right? So if you feel kind of blurry, some people describe it as lightheadedness and things like that. It can be suggestive that there's not quite enough blood flow.
Yeah, she says that stuff happens right away. So yeah. I was just curious.
Yeah, I think that's kind of the
we sometimes call it a gray out.
Yeah.
Okay. It's sort of like everything turns gray and fuzzy, and it's a sign that the amount of blood you're pumping to the brain is insufficient. So the first thing you want to do when that happens is get down and lay flat. And if it's because you haven't been on oxygen, it's clearly a sign you need to get back on the oxygen.
Right. Thanks.
Great.
So just wanted to say thank you to the PHA for having me here, and to Dr. McKlevy and to Dr. Brundage as well as being part of this panel. So I was asked to talk a little bit about diuretics and sodium. So, part of our mainstay to managing pulmonary hypertension are diuretics, which some of you may know as water pills or fluid pills. And we use them because in pulmonary hypertension, as you know, that right ventricle on the right side of your heart works very, very hard to pump blood into the lungs. It becomes a high-pressure, high-volume system. So over time, that heart gets tired because it's pushing that blood so hard into these little tiny blood vessels. So when that happens, we need a way to sort of reduce that pressure on the heart. And we do that by reducing some of that circulating volume that's going through your body. Because if we don't do that, what you will see is you'll see that fluid building up. You see the swelling in the ankles and the feet, can go all the way up to your thighs, and then you get that belly. So we need to find a way to not make that happen. So the way that water pills or diuretics work is that they will help to draw out extra fluid that you have that the normal body would just eliminate on its own. So everybody's dose is going to be different for these diuretics. We may dose them twice a day. You may be on 2 different diuretics because the mechanisms, how they work in different areas of the kidneys to help to draw out the most amount of fluid. So it's very important when you're a patient, you go in to meet with your medical team, they say this is what we want you to do. The first thing that my patients say to me is, do you know how many hours I spend in the bathroom? I can't get out of my house until noontime. And, obviously we recognize that, but it's one of those things. It's just like your pH meds. If you skip those meds over time, your body starts to shut down. So it is important to take them the same time, every day, same dose. With that said, we recognize that there are, things that you do that can sometimes affect those diuretics and the dose that we give you. And there are times that we might need to increase them a little bit. Perhaps you went out to a restaurant and you were very, very diligent about watching what you ate. You ate a salad, but the salad was loaded with sodium, and you come home and you can already feel that water building up inside of your tissues. So, we keep very close watch on our patients, and we say, if you think that you're retaining fluid, you should get on the scale every day. I tell people, same time every day. And if you do that and you notice that you're having a couple pound fluctuation, and every medical team might tell you something different, so I'm not going to say it's this number of pounds and X number of days. That should be something that you work out with your team, but you sort of know what those guidelines are, and if you notice that that's happening, then you call your doctor, you call your nurse, and you say, hey, this is what's going on, and you work it out from there. I mean, we don't want to put you in the hospital. That's not our goal, and we want to avoid that because all the things that come along with coming into the hospital. So, if we can keep a good control on the diuretics in the outpatient setting in the community, it's better for everybody. It really, really is. So one of the things that people tell me all the time is, well, these water pills, I think they're drying me out too much because my mouth is so sticky. I can't, I want to drink. I drink. And I say, well, by doing that, you're basically defeating the purpose. Even though you're probably not taking in as much water as you would be taking out from the diuretics, it's still really working against what we're trying to accomplish. So a little trick that I tell my patients a lot of times is to buy a small tumbler, fill it with ice, and use a straw. And you tend to drink a lot less and more and slower by drinking it that way versus, taking a bottle and just chugging it down, 20 ounces in just a couple minutes. So that seems to work pretty well for people. And a lot of times we put people on fluid restriction, and the minute that I say that to one of my patients, they give me the death stare. But we really do it because this is sort of part of our management plan. And typically, you can, your fluid restriction might be 2 liters. It might be 1.5 liters. It might even be less than that if you're really full of fluid. And we don't do this to be mean. We do this because, we're trying to accomplish this goal that I'm talking about. So, there's some really good resources online. American Heart Association has a great section for patients on fluid and sodium and helps to put things into perspective to people so you'll know, like, if you drink a glass of this or you had a cup of ice, what the equivalent amount in fluid ounces would be. The other thing that you have to think about, too, is that things like Jell-O, popsicles, broth, all of those things count as a part of the fluid that you're taking in every day. So even if you're not drinking glasses of water, those things do, add to your fluid. We recommend that, sometimes the only way that you really know what you're doing is if you keep yourself accountable. So you keep a journal, and in that journal write down what you're drinking for the day. And you don't have to do it you do it for a period of time, but it really helps to keep you accountable. So then you say, wow, really, now I can understand why I'm going over the limit and why I might be retaining some fluid. And lots of people, you hear it everywhere, drink water, water's great for you. Well, we have to sort of educate people that in pH it's not necessarily the case. It kind of goes against what we do. So like I said, just keep in close contact with your team if you're concerned that you're developing extra swelling, your breathing is getting worse, you're getting the big ankles or the big belly. And then on to sodium. So sodium and salt, you've probably heard the old saying, wherever salt goes, water follows. So sodium and water sort of have this love relationship. And if you're drinking a lot of water and you're eating something that's salty, then you tend to hold on to that water more. So, the other thing that people say is, well, I don't even have a salt shaker in my house. And I say, well, what are you eating? And then we go through a typical day, and they're eating a salad with, lots of salad dressing. They're not measuring out. They're eating lean cuisines or other frozen dinners that are loaded with sodium that help to preserve the meals. I say, well, these things have salt in it, and even if you're not taking that shaker and putting it all over your food, it's in there. And they say, oh, well, I use kosher salt or I use sea salt, it's better for you. Well, there may be some benefits to sea salt and kosher salt, Himalayan salt, but as far as giving you some minerals, and it's more natural, what people will say, but it doesn't necessarily take away from the fact that it's still adding sodium to your diet. So you should use just the same caution with that as you would any, just a regular table salt. And like I said, about 75% of the American diet, sodium comes from processed foods. I mean, a lot of what we eat is processed. And that's to preserve things. So things like pickles, olives, canned veggies, boxed pastas with sauces and herbs and spices, which a lot of that is salt that they throw in, really can make you, full of sodium. So right now, the American Heart Association's recommendation is 1,500 milligrams of sodium a day, which that's changed over time. I've heard a little less, I've heard a little more, but as a frame of reference, it's about half a teaspoon. So if you had a teaspoon, you filled it, half of it would be just about what you get for a day. But the shocking thing is that most Americans ingest about 34 milligrams of sodium a day. So way over that recommended limit. So what can you do? Well, the things that I do is I teach my patients how to read labels. You have the nutrition facts on every package of food. There are going to be new ways that they're labeling foods, so you do always want to pay attention to the portion size and how many portions is in a box. So there'll be 3 servings or 1 serving. And to you look at it and say, well, I could eat this in 1 sitting. And you look at the nutrition facts and it actually is for 3. So got to kind of keep that in mind. And it does take a while to do that. You can spend an hour in the supermarket reading labels, but I think in the long run it really pays off. Some of my patients I've sort of made them very hypervigilant about when they go out to restaurants or if they have to go to an event and they say, I don't know what I'm going to do because there's going to be so much sodium in all of this food. I said, well, there's lots of things that you can do. You can bring your own snacks with you that you've packed yourself, what's in them, so that will kind of keep you on the same path that you've been going on. Or now, lots and lots of restaurants are used to dietary restrictions, allergies. If you go in and you say, I'd really like no salt on this or no spices, then they will work with you. And oftentimes the cook will come out to the table and say, I've prepared this special for you just based upon what you requested. So don't be ashamed to ask for that. That's, your right and your privilege as a consumer. So, lots of restaurants also have pamphlets too. A lot of the chain restaurants will have a pamphlet that will tell you what is in each of their meals. So that's also helpful. And then don't be afraid to, lean on your medical team, get involved with your support group. There's lots of great educational resources on the PHA website. There are some worksheets on American Heart that you can use to fill out journaling as far as your sodium and your water intake. Those are, really great. So, thank you.
Hi, my name is Bruce Brundage, and I'm a cardiologist. So, Dr. McKlevy appropriately steered the cardiology type things to me. And one of the myths that was on the list that patients had brought up is, why can't you just do an echocardiogram? Why do I have to have a right heart catheterization? So we thought it would be good to sort of give you an overview of what an echocardiogram is and why we do it and what its advantages are and what are some of the disadvantages of it. And then the same thing about the famous right heart cath. Why do we do it? And why is it important? And what are the limitations? And why don't we do it more frequently? In fact, there's still amongst PH specialists not a complete unanimity of opinion about how often you should have a right heart catheterization. Some centers we'll do it almost on an anniversary basis once a year. Myself, I certainly do a right heart catheterization to make the diagnosis, because it's the most accurate way of measuring the pulmonary pressures. But I don't just do it automatically. I do it again when I think there's some important change going on in the patient's life and health, and possibly if we're changing medicines in a major way, then we would certainly want the accuracy of a right heart cath. So I think all of you that are patients have certainly had an echocardiogram, and probably multiple echocardiograms. It's ultrasound. One patient said to me, a male, he said, "I have that thing, you do with a baby." So everybody who's in their family, if there's been babies, that now obstetricians do ultrasound. So the good thing about ultrasound is that, which is basically high frequency sound waves, is that it's totally painless. It's non-invasive. You can do it as many times as you think necessary. And there are ways to get a good idea of how we've mentioned the right ventricle, the right side of your heart, how well that is functioning. And also there are indirect ways we can estimate how high the pressure in the pulmonary arteries are. Same thing that we want to do with the right heart catheterization. The problem is that that's not always accurate, and particularly in people who are overweight, because there's more tissue between that, we call it transducer, that's the thing they put on your chest to send the sound waves through the heart, and then they bounce back. And so that transducer is both sending it out and receiving the sound waves. And so if your patient has a fairly thick chest wall, then it's got to go through that tissue before it gets inside to where the heart is. And that can make the picture fuzzy. Think of the old days of television. You don't see it much anymore, but remember the old days of television when there was snow, if you had poor reception? Well, it's sort of like that. You're getting poor reception from your ultrasound. And the other thing that goes hand in hand with it is many patients with pulmonary hypertension may have some lung disease too, different lung tissue disease, like patients with scleroderma who often end up with pulmonary hypertension. Or you may have been a smoker in the past and have a little bit of emphysema or chronic bronchitis. All those things interfere with those sound waves getting through to the heart. Your heart sits right here on the left side, and it actually is very close under your chest. That's why you can usually put your hand on your chest to actually feel the heart bouncing against the chest wall. So that's why echo works, is it's not very far for those sound waves to get to the heart. But if you put tissue, fat and muscle in between, or you put other lung tissue that starts to envelop the heart, then it makes it more difficult to get a good echo picture, and then it becomes difficult to make these estimations of your pulmonary pressure. So we do echo because it's easy to do. It doesn't hurt you in any way, shape, or form. And it's relatively speaking, nothing in medicine is cheap anymore, but it's relatively inexpensive compared to some other imaging diagnostic techniques that we might use. And one other advantage of it is we talked a little bit about exercise, and we might actually want to see how your heart works during exercise, and echo would be a good way to do that. You can actually have a patient exercise either on a bicycle that's mounted on the table and you pedal it, or you can actually get up and walk on a treadmill and then lay down quickly and use the echo device to see how the heart is functioning during exercise. So that's another advantage. And I'm just checking my checklist here, which I passed out to you. And finally, the thing about echo is we have a saying I think in the whole world of the digital world we live in, computers and so on, garbage in, garbage out. So putting that transducer on the chest wall requires a highly trained technician. Echocardiographic technicians have a lot of training. And if you don't have a highly trained technician, then the images you get may be misleading and inaccurate. And so it is, and so that in a sense is one of its limitations, is we have to have very highly skilled people to do the echocardiograms. And then briefly, the famous right heart cath. Every one of you that has been put on pulmonary hypertension medicines have had a right heart catheterization. And why do we do that? Well, we talked, Dr. McKlevy talked a bit about the blood flow in the boxcars. The flow measurement, which we call cardiac output, which is the amount of blood your heart pumps per minute. The most accurate way we can measure that is to put a catheter into the right side of the heart and into the pulmonary artery. It's done simply by a thermistor, a device that measures temperature sensitively, and you just inject some cool salt water in, and that will change the sensitivity of the thermistor, and from that we can accurately compute cardiac output. The other thing we measure, as I said, the echocardiogram can give us indirect ideas about how high your pressure is in your pulmonary artery, but the only way we can accurately measure that is actually through the catheter to a sensitive, we call it transducer, that actually is ultra sensitive to changes in pressure, and we can actually see the whole shape of your pressure curve, which gives us some valuable information. We also can measure indirectly the pressure of the left heart, and that, without getting too complicated about it, it is important to know what's going on with the left heart in a patient with pulmonary hypertension. And from that, we compute something we call resistance. And if any of you took high school physics, you remember Ohm's law, I equals E over R. It's the same law for flow of fluids. And so that we can compute the resistance of the blood, which is the impedance to the blood flowing through. Those boxcars have to go through ultimately tiny little vessels we call capillaries, and it's there that the oxygen is let out and into the lung, comes out of the lungs, and the carbon dioxide is let out to go for us to breathe out. And if those tiny vessels just before where that exchange takes place get narrowed, as they do in pulmonary hypertension, you can imagine it becomes very difficult to push that through. You can think of, if you take a hose and you put a nozzle on the hose and you have it wide open, the water sort of comes out like this. You squeeze down on the nozzle, and now the force is really great that comes out. Less water is coming out, but it's the force that's coming out, and that's because the resistance has changed by you screwing it down. And you can imagine every one of those little blood vessels gets screwed down, and that makes it hard for the right ventricle to work, and leads to all the symptoms that we see in pulmonary hypertension. So the limitations are, why don't we do it frequently? Why don't we do it once a month? Well, you wouldn't like that, would you? It's invasive. I mean, we do it with as little discomfort for you as possible, but I don't think anybody would say, oh, I'd love to come in and have another heart cath, because it's costly. It's much, much more costly to do a heart catheterization than do an echocardiogram. And one other disadvantage is that, which is an advantage of the echo. When we do the echo, you're just lying there on the table and you're pretty much in your natural resting state. When I bring you to the cath lab, often you get a sedative, which may change the pressure measurements. And you may be a little anxious and upset about it because you know it's not an easy thing to go through, and it's sort of scary. You're in this big room, all these machines, and so that causes you to be anxious, and that can change your pressure measurement. So even though it's the most accurate measurement, we might be actually measuring the pressure when you're very anxious, or conversely when you're markedly sedated. So those, I think, hopefully will give you some ideas to ask me and Mary and Dr. McKlevy about diagnostic techniques. Thanks.
My question is regarding exercise and how far you can push yourself, and if there are any recent studies about it. And why my question? Because I'm on Tracleer, Adcirca, Coumadin, and Lasix, and I'm doing really well. I'm bike riding. We are bike riding probably between 20 and 30 miles every weekend. The farthest I have gone is 30 miles, and I'm trying to improve. So how far do you recommend going, and if there's any studies?
Well, first of all, congratulations that you're doing well enough to do that much exercise. So we applaud that. So I was saying, there's not an exact number, right? It's really all based on your capacity and how you feel. So if you're riding 20 miles a weekend and you feel fine and don't feel limited, that's great, right? So it's important, whoever your personal doctor is too, it's important to talk to him or her because they will know them much better than any of us will. But it's really just, it's limited on how you feel. So if you don't feel lightheaded, you don't feel overly fatigued, you're not having muscle cramps, then you're doing the appropriate amount. But you have to kind of know yourself to know what are the prodromes to passing out. Because it's easy for us to say, don't pass out, but 1 second you're awake and 1 second you're not. And so you need to start sensing any of the things that might, fogginess of your eyes or tingling of your hands or some of the things that can be suggestive of not enough blood supply.
One of the things that is often said about exercise in healthy people, no gain, no pain, no gain. Not true when you have pulmonary hypertension. You don't want to ever push yourself to the point of physical discomfort because you could seriously harm yourself.
One of the things that we do at our center too is enroll our patients in pulmonary rehab. So if you have the opportunity to go to pulmonary rehab, I would highly recommend it. Even if you've been someone that's exercised for years, the cardiopulmonary rehab specialists in the program are trained, at least at our center, to work with our PH patients and to say, hey, I think you might be pushing yourself a little bit too much. And they will help our patients before they're discharged from program to come up with an exercise regimen that is going to work for them. So I am a strong believer in their program.
I have two questions. First, the difference between echo and right heart cath, there's usually a variance. What's generally the percentage of variance of accuracy between those two? Because one number will come out this number and the other one will come out this number, and they are generally not close.
Right. So I think the question is, what is the comparison between the measurement of pressure by echo, or the estimation of pressure by echo, and the measurement that we obtain in catheterization, and why is that number different, and how much does it vary by?
That's the one.
Yeah. First of all, there was actually a poster here on the very thing that you're asking, the comparison between echo and right heart catheterization. And what the message that I took away from it was that actually the echo is pretty sensitive. In other words, someone has high pressure, it's usually not going to miss that person. But what happens is it's what we say less specific, because they categorize the patients in various groups, very high pressure, mid-range pressure, and elevated but on the lower end. And that was the area where there was the most disagreement between the catheterization and the echo. And the echo what the echo does, there are a couple of things that's most commonly done is our blood pressure and our pulmonary artery pressure both have two measurements. When you do the blood pressure cuff on your arm, the doctor always and nurse come up with two numbers, the systolic pressure and the diastolic pressure. So often they tell you what your blood pressure, your blood pressure is 120 over 80. So the same thing is true in the pulmonary artery. In a normal pulmonary artery, it's about 25 over 10. But what the echo most commonly is estimating is just that upper pressure, the systolic pressure in the pulmonary artery. So it's a higher number. Often the number that we give you from the catheterization is what we call a mean pulmonary artery pressure, which is roughly 2/3 of the difference between the diastolic and the systolic pressure. So that's one reason right there. You're not exactly comparing apples to apples. It's more like apples to
kumquats.
Yeah, kumquats. So that, and then the way we estimate the pressures, as I said earlier, requires that we get a really good, clear picture with the ultrasound. And if we're not getting a clear picture, then we may miscalculate the number. The calculation is straightforward, but we may miscalculate it because we didn't really see all the information that we thought we were seeing, and therefore it's an inaccurate measurement.
Question number two.
Real quick that it also can be variable depending on what your underlying reason for just that depending what your underlying cause for the pulmonary hypertension is, that also can cause a little bit of discrepancy amongst the echo reading. So in some disease states it's better, in some other disease states it's not as good. And so you take all comers, and I know your question was what percentage is it inaccurate, and that is a tough question to answer because there is so much variability amongst patients and all the other caveats that Dr. Brundage had mentioned.
And once it's been measured and we think it's a reasonable measurement for you, then if things change, we have a lot more confidence that we are actually detecting the change with the echocardiogram. If we know from the beginning it's been difficult for whatever reasons to estimate it with the echo, then we may have to resort to the right heart cath more frequently because we know we can't rely on the echo.
Question number two is altitude. Altitude.
Altitude?
Altitude.
Altitude. We have a house in the mountains that we can't live in. Is there a way to, during the testing process, to simulate altitude?
Okay. The answer is yes. It's but it's kind of you're going to need a really specialized center to make that. You're going to need a very specialized center to do that. And what they do is give you sub-atmospheric oxygen. And we do this for some of our patients that have emphysema and some other diseases, but not all. That's done in a pulmonary function lab usually, and not all facilities have that. So that would be can it be done? Yes. I don't. Do you guys do it? Do you do it at your center? Okay. You can go to Rhode Island.
Well,
They're at sea level.
her doctor is Roham Zamanian, and he said you need to go to Boston to do this.
Yeah.
And I'm not resisting. I'm just questioning: is that doable?
Yeah, and what it's going to tell you is really how much oxygen she needs when you guys are at that level. We know it's more than what she's going to need at sea level, but how much more is really the question.
How will they, if that's done, it goes back to my other question. Is that measured by echocardiogram or is it measured by right heart cath?
No, it's actually done in a specialized machine in the pulmonary function lab where we measure oxygen at rest on room air we're at sea level, and then we begin administering that oxygen, and then we just start to crank it up in intervals.
So it's done during the procedure?
Yes, it's
okay.
Non-invasive.
Okay.
A non-invasive procedure. But it is an estimation. So we don't take those results as gospel because we can't always predict what will happen at altitude. I think we can have a good idea whether or not somebody will need oxygen or what their desaturation looks like at higher levels, but it's not perfect.
Thank you.
You bring up a good point that we might discuss for a minute, and that is that is it okay for patients with pulmonary hypertension to go to places that are at higher altitude? For instance, if you live in Rhode Island, where Mary is, they're close to sea level. Where I live, it's 3,500 feet, and that's a significant difference in your oxygen level. Or if you go to Denver, it's 5,000 feet. And so patients often would ask, is it safe for me to go to Denver? That's a big place, so people go there. The way we get to Denver, particularly if you live in Rhode Island, is we get on an airplane. And guess what? The amount of oxygen in an airplane is about the same or even a little less than what it is in Denver. So that's why you discuss with your physician about the safety of flying and whether or not you need oxygen while on an airplane, because the oxygen, although people with no heart disease don't notice any difference at all, a person with certainly pulmonary hypertension or other forms of heart disease may well notice the difference. The other thing I would say, because I used to practice in Denver, Colorado, is that most patients, and I took care of a lot of PH patients in Colorado. One of the biggest centers of pulmonary hypertension in the country is in Colorado. So people go there just to see the specialist, is that when you go to altitude, as Dr. McKlevy talked about, those boxcars are going to be carrying less oxygen, and you need to, and therefore your heart's going to work a little harder, and so you need to take it easy when you go there, and usually it takes 2 to 3 weeks to fully acclimatize even a person with a normal heart and lungs. It takes 2 or 3 weeks for the system to acclimatize to that altitude. But most people, not all, but most people with pulmonary hypertension can successfully live at altitude. I would never recommend that you go to high altitude. You're not going to want to climb Mount Everest. You're not going to want to climb any mountain of 10,000 feet, which are a lot of those in Colorado that are over 10,000 feet. But you could certainly, most patients could go to an altitude like Denver of 5,000 feet and still be able to live a reasonable life.
I was just going to tie on to that, just to kind of close the analogy of the boxcars. In that 2 to 3 weeks when you're acclimating to altitude, you're actually making more red blood cells. Your bone marrow starts making more red blood cells, and thus then you have more boxcars to carry around.
More boxcars.
Why can't they just give you some more red blood cells?
Well, that is one way to do it. So one of the things they'll check on some patients is making sure that you're not too anemic, right? Because that can be unsafe. But then there's risk to transfusion, back to the volume situation and blood and salt and too much volume. So it's a balance.
Thank you.
Great questions. Does anybody else have? We have a few more minutes. Oh, sorry.
I don't really know how to ask it, but if you pretty much significantly over stress yourself, unbeknownst to you, because I've never gone through cardiac or pulmonary rehab, but and now I think I'm seeing some, I don't know where the symptoms are coming from, but I went, in the end of May, the whole question comes from, the end of May, I went to San Francisco. I live between Houston and Austin. I walked 16.7 miles in a walk with my daughter. So I flew there, flew home, had sort of kind of trained for that. And as I hear people saying dizziness or kind of lightheadedness or whatever, I experienced some of that during that walk. It was nice, 53 degrees, so that was great. And we had stations which we stopped. But now I'm having all kinds of swelling, and so I don't know. And I've just gotten pre-op clearance from a cardiologist and my pulmonologist for shoulder surgery on the 29th. So I'm kind of a little, confused. And my numbers and, the 6-minute walk test is great. And my other question is, I have a rheumatologist, pulmonologist, and cardiologist like most people. But what I'm hearing is there's a lot of more specialized treatment that are evaluations and assistance that might go on in a center for pulmonary hypertension. And so would you recommend that you maybe go to one of those that then can work with the team you already have? Because I have Dr. Julie Wynn in Houston, and Howard Rubin is a cardiologist I have, and Holly Jones is a rheumatologist I have. So, and they're all great doctors, and when you tell some people about them, they're like, you have some of the best. But would it be beneficial to also go to a center that specializes in pulmonary hypertension?
We're probably all going to say the same thing, I suspect. So first of all, I'm very familiar with all three of your physicians. I've known Julie for a very long time. She's great. So nothing to undermine any of those guys, right?
So basically, I think she's saying, would it enhance her treatment to go to
sometimes
a center?
So, a big push in a lot of the guidelines and recommendations these days is to at least be seen in a center at some point, just so that all the T's are crossed and all the I's are dotting, and that there's not, they're probably doing everything perfectly. Nobody would say they're not. But if there's something that there also is out there, to give you that opportunity at least once to have that conversation with, Dr. Bruce or Mary or our group or whoever. Where you guys live, there's centers in San Antonio, there's centers here, obviously, there's centers in Houston, whatever's convenient for you. Gosh, I lost my thought. So it's something to consider, definitely.
Yeah, the thing about the centers, which is, as you've heard, a new initiative of the PHA, is that I would strongly recommend that you go and have an evaluation at a center fully with your doctor's approval and knowledge. Because those centers have their finger on the pulse of everything that's going on in pulmonary hypertension. Your cardiologist or your pulmonologist has to have their fingers on the pulse of many diseases and problems. But the centers have their finger on the pulse of pH specifically. And there may be something new that's coming around the bend that would be a benefit to you, whether it's diagnosis or treatment, and then you're in the loop. And then you can go back to your doctor and once a year or whatever seems appropriate, you visit back, and then that site also knows you. If something new does come up, they'll get a hold of you. So I think you want as many people on your team as you possibly can, but you definitely need the doctors that you see every day to be in the loop with what's going on.
And just to add to that too, I think that the communication is very important, and that is one of the beauty of being in a center, is that oftentimes we have very good relationships with the other specialties. So, you know, I can pick up the phone and call and say, I have this patient and I'd like you to take a look at them, which is often what we do. But to add to that as well, I also think that it's very important for patients and their family members to advocate. If you feel that you need an evaluation or something just doesn't seem right, then you have the right to sit down, have that conversation, and talk about it. And, you know, come to your appointments and make sure that you have your records there. Just makes things go so much smoother, and helps us get you the treatments that you need. The other thing with going to a center is that you have the opportunity to potentially participate in some clinical trials for cutting-edge treatments and pulmonary hypertension. So, you know, that is definitely something that we are, you know, able to happily offer to many of our patients.
I was at one center. I go around and do the reviews for these new centers that are opening up, and one center had in their application that 85% of the patients in their program have participated in a clinical trial. So what Mary says is absolutely critical, that every PH patient should know that they have the right and the opportunity to participate in a trial if they choose to.
And then to just touch back on what you started with, which was you had kind of an exertional event, and sounds like you did okay with that. And so when we talk about limiting yourself with exercise, it's really in the moment, right? Like if you walked 15 miles and said, I'm okay, if you get lightheaded, you should stop, right? If you get grayed out, you should stop. But then it's right then, like now that you're having swelling, like after the fact, I'm not quite sure that those two things are intimately related.
Not necessarily related.
Right.
But some patients think that if they've gone through some exercise event, and then 2 weeks later they have a problem, that they somehow hurt themselves during the exercise. Almost never that is the case. What you want to do is listen to your body. And if your body told you felt fine walking 15 miles at the pace that you were able to breathe easily and so on, you're not hurting yourself.
I think it's probably important at this point to get in touch with Julie and, you know, maybe check some labs, you know, have that conversation, because I don't think that those things are related. Just think about it, like your body's got to put blood to one or the other, right? So if you're doing upper arm weightlifting and then you're going to do lower, then your heart's trying to shunt blood to both at the same time. That's really the caution.
Yeah. You want to do things gradually. Right. I mean, as a cardiologist, so often I've seen, not necessarily with pulmonary hypertension alone, but other heart diseases as well, somebody gets the idea that, you know, I'm out of shape, you know, maybe I'm a little overweight and I'm gonna get on a program, and they go out and in the first day they try to do this incredible workout. That's how you hurt yourself. Mm-hmm. If you gradually increase what you're doing, I don't care if it's elliptical or whatever, you can do it. Just do it gradually, and you can build up the efficiency of your muscles, as Dr. McKlevy pointed out, and you'll likely feel better. You'll increase that 6-minute walk by, what was it, 96 meters?
In that one study.
That's amazing.
That's amazing.
It is great.
Amazing. You had a question, ma'am?
I was just curious how much water your body can retain before you notice it.
Good question.
That's a very good question. I don't know that there's actually a number.
It depends on how big your body is.
Yeah.
And your kidneys.
You know,
Yeah.
and if you have a lot of subcutaneous tissue, you may be able to hide it before you recognize it, whereas if you're skinny as a rail, you may notice a relatively small amount.
Right. It's not uncommon for us to see somebody who's in severe right heart failure that I'd say almost looks like the Michelin Man. They come in, they're so full of fluid, and we can take liters and liters of fluid off in the first, 48 to 72 hours. And we have to do that pretty slowly because your body, your heart, even though it's not pumping efficiently, has become accustomed to this amount of volume, so that we don't drop your blood pressure rapidly. We do have to have, monitor you very closely. And that's, if I saw someone like that in my clinic, I would admit them to the ICU and diurese them very slowly and cautiously. I wouldn't say, well, let's double your water pills for the next 2 days and call me and let me know how you did. Sometimes they do. I think sometimes people think that, they can adjust the doses of their medications and, not eat any salt for a few days and see if that gets better. I mean, I think we all know lots of our patients, we've made them very independent. They want to continue to work. They have families. So it doesn't always become a priority. And by the time that they get to us, it's the 11th hour. And now, we're having to try to come back from a point that you can't really manage in the outpatient setting.
But Mary mentioned to weigh yourself daily.
That's the point.
Same thing for the cardiology patients as the pulmonary hypertension patients. Daily weight will give you that clue if you're starting to put fluid on.